I'm Atra Nazra, Program Director for Integrative and Planetary Health at the OSHA Center for Integrative Health at Harvard Medical School and Brigham Women's Hospital. Thank you for joining us today. On behalf of the OSHA Center and in recognition of Earth Month and Earth Day on April 22nd, I'm delighted to introduce our Grand Round speaker for today, Dr. Gregg Furie from Brigham and Women's Hospital. And Dr. Furie will be speaking on the topic of climate change, human health and sustainability, intersections and opportunities for the health sector. So thank you, Gregg, for joining us today. Climate change is considered by many to be the greatest public health threat of our time. And unfortunately, the health sector is a significant contributor to the problem. In his presentation, Dr. Furie is going to show us how climate change adversely affects human health, how healthcare delivery contributes to climate change, and how healthcare systems, both in the US and abroad, are working to improve the health and well-being of patients and the planet. Dr. Gregg Furie is the Medical Director for Climate and Sustainability at Brigham Women's Hospital, an associate physician in the Division of General Internal Medicine and Primary Care, and an instructor of medicine at Harvard Medical School. He works to prepare clinicians to address current and emerging health threats from climate change and to reduce the environmental impact of clinical care. He is a member of the Brigham Climate Action Council and the Mass General Climate and Sustainability Leadership Council. Dr. Furie graduated from Princeton University and Harvard Medical School, completed residency in internal medicine at the University of Pennsylvania, and was a Robert Wood Johnson Foundation Clinical Scholar at Yale.
Great. Thank you so much for the kind introduction and also for the invitation to speak to you all. It's really a pleasure to have this opportunity. First of all, I have no conflicts to disclose. And then we're going to start with just a little bit of background. The current concentration of CO2 in Earth's atmosphere, shown here at around 417 parts per million, is unprecedented in the past 800,000 years. The previous highest CO2 concentration is here, about 300 parts per million. And we know that this rise is due to human activity, primarily the combustion of fossil fuels, deforestation, and certain agricultural practices. As you can see in this middle panel, atmospheric CO2 concentration that's shown here in blue really tracks closely with CO2 emissions that are shown here in gray. And as I suspect most of you are aware, these rising CO2 concentrations are highly correlated with average global temperatures, shown here in the red bars. And as becoming increasingly clear with each successive extreme weather disaster, both locally and globally, the implications for human health are truly sobering. For example, you may recognize this is the massive flood following torrential rains and a dam collapse in Libya, which reminded us not only of the risks associated with the failure to curb global temperature rise, but also the danger of not preparing for the inevitable consequences of climate change. And that's why recently, for the first time ever, over 200 medical journals, including some pretty reputable ones, published a joint editorial in which they stated that the greatest threat to global public health is the continued failure of world leaders to keep the global temperature rise below 1.5 degrees Celsius and to restore nature. And of course, the health effects of climate change are not limited to the impacts of extreme weather events, right? So this is a figure from the New England Journal of Medicine that shows how increasing levels of CO2 and other short-lived climate pollutants are driving rising temperatures, rising sea levels, and increasing extreme weather events. And through various exposure pathways shown down here, are having some very direct and very indirect effects on human health, affecting essentially every organ system in the body. We're not going to go through these in detail, but the health effects of climate change are broad. And importantly, the magnitude of those effects and their distribution amongst populations are influenced by a number of demographic, socioeconomic, and environmental factors. And it's critical to point this out because we know that climate change disproportionately affects the health of the most vulnerable populations. Many people believe that climate change is the greatest public health challenge of our time. I'd also argue that it's the greatest health equity crisis that we currently face. And for those of us in healthcare, there's a paradox, and that is that we're a major part of the problem. If the global health sector were a country, it'd be the 5th largest emitter in the world, and the US would be the 13th largest emitter. The US health sector is responsible for about 25% of global health sector greenhouse gas emissions and nearly 10% of total US emissions. So the health sector is having a significant impact on the climate. And so many of you may recognize this as the Longwood medical area where I work, where there are 3 quaternary care centers operating 24 hours a day, a major cancer center, a power plant, all within a 3-block radius. And when you think about kind of the scale of just this, and then extrapolate that to the larger health sector and what this means for kind of our environmental impact, you can really begin to appreciate that it's substantial. And that environmental impact is exerted through many different pathways. For example, through manufacture and dispose of all the products we use, transportation to and from our facilities, agriculture from all the food that's being served, water use, and of course, just all of the energy associated to power, heat, and cool all of our facilities. And I would say as healthcare professionals, this should matter to us because we know that healthcare-associated pollution, including contributions to climate change, adversely and inequitably affects human health. This is data from a paper that came out in the past few years, basically estimating the impact of environmental damage from the health sector at around 245 to 530,000 disability-adjusted life years annually. And if we agree that contributing to death and disease through the environmental impacts of our operations is fundamentally at odds with our mission, then we have to recognize that we need to be doing something about our environmental impact. We've made a commitment to first do no harm, but in fact, the very act of delivering healthcare right now is having effects on the environment that are adversely affecting human health. Today, we're going to focus primarily on greenhouse gas emissions, although, as I mentioned, there are other forms of healthcare-associated pollution that harm human health. But in terms of greenhouse gas emissions, some of the best data that we have comes from a recent carbon footprinting analysis of the UK's National Health Service. This diagram shows sources of emissions for the NHS using a typical framework for greenhouse gas accounting, which divides emissions into Scope 1, Scope 2, and Scope 3. So Scope 1 refers to emissions that are produced directly by facilities, including on-site fossil fuel combustion, released anesthetic and refrigerant gases, and those from an organization's vehicle fleet. Scope 2 emissions are those that are attributable to energy that's purchased by an organization, but not produced by it. So think about the electricity, primarily the electricity that we purchase, but also we purchase steam, we purchase chilled water. And then Scope 3 emissions are those that are attributable to our supply chain, our waste streams, our water use, construction, transportation. And importantly, greenhouse gas emissions include not only CO2, but also other gases that are commonly used in modern medicine that contribute to the greenhouse effect, many of which have a far greater heat trapping potential than CO2, such as inhaled anesthetics and propellants in meter dose inhalers. This chart shows the relative contribution of different aspects of healthcare delivery to the NHS's greenhouse gas footprint. Notably, Scope 1 and 2, which include building energy, anesthetic gases, and the NHS vehicle fleet, really represent a relatively small proportion of their total carbon footprint. Some Scope 3 emissions that are directly under the control of the NHS, such as patient staff travel, meter dose inhalers, water and waste, make substantial contributions. And business travel is also an important one to note. But the largest proportion, 62%, comes from the supply chain, including a relatively substantial proportion that comes from pharmaceuticals. This is data from a similar analysis of the US healthcare system that again shows Scope 1, Scope 2, and Scope 3 emissions from 2010 until 2018. Most recently, in 2018, US healthcare associated emissions represented 8.5% of total greenhouse gas emissions in the US. The per capita emissions from the US healthcare sector are the highest in the world, not something that we should necessarily be proud of. And similar to the NHS, Scope 3 emissions really represent a substantial proportion of US healthcare emissions. And a few important things to note about this analysis is that it doesn't include contributions from meter dose inhalers or anesthetic gases, which are likely substantial. And none of these analyses that I've showed you show emissions associated with institutions' investment holdings, which we think are basically on the same order of magnitude as our Scope 3 emissions in general. They also don't include the presumably substantial impact of biomedical research that's conducted at many academic medical centers like ours. So I've hopefully convinced you that the healthcare sector is making a significant contribution to climate change and other environmental pollution with attendant harms to human health. The question is, what can we do about it? Well, just as with the climate crisis as a whole, there's really no single solution to healthcare sustainability. We're going to need to implement a suite of changes that reduce our environmental impact while maintaining or improving clinical outcomes for our patients, as highlighted by this wedge diagram that outlines how the NHS is thinking about achieving zero greenhouse gas emissions across all scopes, which is also known as net zero. And I'm not going to go through this in detail, but I want to point out that the interventions fall into broadly 4 categories. The first is decarbonization of the electrical grid and transportation, changes in healthcare utilization and delivery, implementation of local sustainability solutions, and decarbonization of the supply chain and product circularity. So we're going to talk about 3 of these in a little bit greater depth, with a particular focus on healthcare utilization and delivery, because I think there's some real kind of intersections here with the work that you all are doing. It seems obvious, but it's important to point out that clinical care is really the primary driver of healthcare's environmental impact. And it's relevant because we know that hundreds of billions of dollars of US healthcare spending is just waste. And that's not trash, but we also produce a lot of rather unnecessary care that comes not only with a high financial cost, but an extraordinary environmental cost as well. So we could dramatically reduce our environmental impact through things like reducing just the volume of clinical care that we provide, through better disease prevention or advanced care planning at the end of life, by avoiding delivering care in more resource-intensive settings like the ED or the hospital, through better chronic disease management, caring for ambulatory sensitive conditions in the outpatient environment, or through increased use of telehealth for ambulatory care that doesn't require being seen in person. And also by just minimizing low-value care, which we know there's a lot of, things such as unnecessary testing, procedures, or treatments that do little to benefit patients, in fact, may cause harm, but has a significant financial and environmental cost. And when I think about the work that all of you do, again, I think this is an area where I see a really such significant potential for the role of integrative health to address the healthcare contribution to the climate crisis, because so much of what you do is focused on either disease prevention or approaches to disease management that are less resource intensive than allopathic medicine. So let's talk about a few examples where I see there's real potential. The first is around disease prevention. We're going to talk a little bit about this idea of climate and health co-benefits using dietary change as an example. And so for the past, I would say 15 years or so, people have really started to recognize that many solutions to climate change are also health solutions. And nutrition is a great example of it, because we know that a significant driver of the climate crisis is our current agricultural and food systems. Similarly, we know that nutrition is a major driver of chronic disease, and I think there are many opportunities to solve both of these problems with the same solution. So this is a work that was done by the Eat Lancet Commission that basically set out to identify a diet that could do a few things. First is optimizing human health based on appropriate micronutrient intake, ensure that all people in the world could receive a diet of at least 2,500 kilocalories per day, provide some flexibility in that diet so that it was adaptable to different dietary patterns and their variation across cultures. And lastly, to not exceed any planetary boundaries, or by which I mean sustainable limits to environmental impacts, which included not only greenhouse gas emissions, but also cropland use, water use, nitrogen and phosphorus application, and biodiversity loss. And you may not be surprised to hear it, but the diet that they identified that meets all of those objectives is one that's largely plant forward, heavy in fruits and vegetables, significant whole grains and legumes, and relatively little dairy or animal source protein. This is kind of the relative contribution of those different food groups to this diet, and I'm going to show you a little more about the environmental impacts in a second. But they estimated that if the entire world were to move to the planetary health diet, that we could save an estimated 11 million annual deaths could be prevented. This chart on the left is basically showing us, for different regions of the globe, for each of these different food groups, what current consumption patterns look like relative to that optimal amount that was specified in the planetary health diet. And so let's just look at red meat, for example. You can see North America, Europe, Latin America, and East Asia and Pacific are significantly exceeding what would be allotted to us in the planetary health diet. Similar patterns for starchy vegetables, and you can see that much of the world is not eating the amount of vegetables, fruit, legumes, whole grains, or nuts that would be necessary to shift to the planetary health diet. And then this is a chart that shows kind of how this begins to help us stay within some of those planetary boundaries. This one focusing specifically on greenhouse gas emissions. So the bar on the left basically shows current emissions related to our agricultural and food systems. So we're just over, so they've set the planetary health boundary as at 5 gigatons of CO2 equivalents per year. And the reason it's above zero is because the idea is that as you shift to the planetary health diet, ultimately the biomass that you're producing is consuming that same amount of CO2 per year. Right now, we're exceeding that 5 gigaton threshold. We're at 5.6. If you were to shift over to the right here, this would be the planetary health diet. If we were able to remain within that 5 gigaton CO2 budget, but while also ensuring that many parts of the world where there currently are not able to have diets of 2,500 kilocalories per day, you see a significant shift not only in the total CO2 emissions, but also the relative distribution of those emissions. So the rest of the world would, much more of our carbon budget for food would go to the rest of the world, and a much less, a smaller percentage to some of the larger and more developed countries in the world. Let's switch to a different example. This is disease prevention, focusing on Tai Chi Chuan or Tai Chi. And I think this group is probably aware that this has really potentially profound impacts for disease prevention. So we know that we spend about $50 billion per year in the US for falls in adults that are over 65. And those falls are likely associated with a significant environmental impact. Not all of them result in significant trauma, but a certain proportion do, that then have to be treated in an environment like this, which is clearly very intensive from a resource perspective, uses a lot of energy. We know that the OR is one of the hot spots for our environmental impact in the hospital. Much of this could be avoided through better disease prevention and fall prevention efforts. And we know that Tai Chi, there's good evidence showing that Tai Chi is associated with a lower incidence of falls compared to other approaches like just stretching or mixed modal exercise. And the number needed to treat in order to prevent one fall is relatively small, 11 people. So investing in these types of approaches could help us avoid a lot of not only the disease burden associated that leads to this type of treatment, but also the environmental impact. And I just want to point out that as we think about this, though, we have to be careful not to jump to conclusions, and that full cost accounting is really necessary. So there is some environmental impact associated with this. People have to travel to and from a facility to participate in this class. And so what we really want to know is what are the emissions like how many people would need to participate in this, and what are the emissions associated with that in order to avoid the impact of just a single, more resource-intensive consequence of a fall like this. An example of low-value care. So we know that chronic low back pain is really prevalent. In the US, in 2016, we spent $134 billion on low back pain and neck pain. That was more than we spent on any other condition. And what we know about kind of treatment of low back pain is that it is associated with low value care. Things like inappropriate imaging, medications that have not been shown to be effective for treating low back pain, epidural steroid injections, which I think the evidence does not suggest are highly effective, and surgery, which is frequently used even in patients for whom it's inappropriate, and surgical techniques are used that haven't been shown to be beneficial based on the evidence. So this is rampant, and it's, again, not only associated with potential patient harms and financial costs, but also environmental harm. And I think the evidence is pretty strong, showing that many complementary and alternative therapies are preferred treatments for chronic low back pain. And again, many of those interventions are not resource intensive from a financial standpoint or from an environmental standpoint. And so there's a strong argument for trying prefer to using those approaches as opposed to some of the others that I mentioned, not only as a way of reducing costs, but also to reduce our environmental impact. Again, I think some full cost accounting is necessary to really understand the relative benefits. I think it's probably safe to say that our financial and environmental incentives are aligned here, at least at the whole health system level. You could argue at an individual health system in a fee-for-service world, there's still some benefit to doing some to pushing some of this low-value care, which is probably why it still remains. But I think we need to start thinking about these aligned incentives as a way of driving change. Okay, and then one last example of low-value care. I just want to focus on supplements a little bit because I find myself falling into this trap sometimes, and I think it requires all of us kind of reframing our thinking a bit. I'm going to talk specifically about omega-3 fatty acids, but I think this could be applied to many other supplements, multivitamins, vitamin D, that I think are commonly prescribed or recommended in modern medicine. So the omega-3 fatty acid supplement business is a $2.6 billion global industry. It's huge. And it turns out that it has a really substantial impact on pelagic fish populations. So pelagic fish are the fish like sardines and herring that are basically at the bottom of the food chain and support all of the larger fish populations that rely upon them. In addition, there is significant environmental impact from the packaging, transportation, distribution of all these products. And really, the data doesn't support the use of omega-3 fatty acid supplements for primary or secondary cardiovascular disease prevention, despite the fact that that is why they are commonly taken by patients. And that's kind of highlighted here in this Washington Post story. There is some evidence for icosapent ethyl that's stronger than I think for omega-3 fatty acids in general, but that is only available as a prescription product. And so I think the point of this is that, but what I think we often, or I find myself saying to patients sometimes, is that it's not clear that there's a benefit to these products, but at the same time, they're not likely associated with any kind of specific harms. And so if you feel strongly about wanting to take something, then I'm not opposed to it. But I think I'm recalibrating my own thinking about this because these things are associated with some harm, right? It may not be to that individual patient, but it is having an impact at the broader population level, both environmentally, and then I think that translates into impacts on human health as well. We're going to shift to local sustainability solutions, and I think this is, I think in some ways a little less relevant to your all's practice. I think it's more applicable to many of the more resource-intensive settings in which we provide care, but it's important to point out that much of the care that we provide is appropriate. It's in the right setting, it's high value. The challenge for us is to figure out how we can deliver that care in a manner that maximizes clinical outcomes while also minimizing environmental impacts. And I think some of the approaches include purchasing renewable energy and energy conservation, using environmentally favorable products, in particular focusing on choosing reusable as opposed to single-use devices, and implementing environmentally preferred purchasing programs, reprocessing of many devices that are labeled as single use by their manufacturer, so they're FDA approved to be used multiple times if they are reprocessed in the appropriate way, utilizing low carbon clinical pathways, minimizing professional travel, optimizing waste segregation, and offering plant-forward food options to our patients and to our staff and visitors. So I'm going to provide one example of kind of single use versus reusable, focusing on isolation gowns, because I think it highlights the way we should be thinking about this. This is data from a life cycle assessment of single-use disposable versus reusable isolation gowns. Life cycle assessment is a tool that basically allows us to compare the relative impact, the environmental impact of two products or processes over their full life cycle. So from the time of manufacture to the time of disposal. And so this assessment assumes that reusable gowns are laundered 60 times before they're thrown away. And when compared to single-use gowns, over an equivalent number of uses, the reusable gowns generated 30% fewer greenhouse gas emissions, 41% less blue water. So that's water that's essentially lost to the environment in the manufacturing process. And they produce 93% less solid waste. Interestingly, there's new data that actually shows that some of the reusable gowns are actually more effective from an infection prevention perspective as well. And I think what we found about many of these studies of reusable versus single use, despite the argument that single use are better from a financial perspective, it turns out that reusables are often cost saving. I want to kind of take a brief detour here just to comment on waste generation in healthcare. We know that healthcare produces a lot of waste. We're the second largest producer of waste in the US, 29 pounds of waste per bed per day, more than 5 million tons annually. And much of that is non-hazardous and could be recycled, but we inappropriately put much of our waste into kind of the hazardous bins, and they're much more expensive, and managing that is worse for the environment because it has to be sterilized before it can be disposed of properly. Operating rooms, as I mentioned, are responsible for a lot of our impact, and so over 30% of the waste that we generate. And as I just mentioned, up to 90% of that waste can be inappropriately disposed of as regulated medical waste or red bag waste, and a significant portion of it could be recycled. And I think this next point is the one that's most disturbing to me, is that for every pound of waste that we produce in the hospital, 32 pounds were produced in the manufacture and distribution of that product. And the waste that we produce has a range of environmental impacts, and it's really complex to manage. So we need to start thinking about how we're going to do a more effective job of minimizing our waste and properly segregating it. I mentioned travel, and so recently we've seen a number of these studies coming out showing the environmental impact of much of our travel to professional conferences. So these are a few studies showing the environmental impact of traveling to some of these professional meetings. The American Thoracic Society, and all of these are focusing just on the air travel. So for the American Thoracic Society, the impact was equivalent to driving 24 million miles. The Radiologic Society of North America in 2017, equivalent to driving 99 million miles, and the American Psychiatric Association in 2018 and 2019, equivalent to driving 50 and 54 million miles, respectively. So our travel is having a significant impact, and while I think there's value to many of the meetings we attend, I think we also need to think about kind of other ways in which to network with our professional communities, to learn. I think we learned a lot during the pandemic, and we should be working to apply many of those learnings going forward, because this really is a substantial impact. And then lastly, I'm going to focus on kind of decarbonization of supply chain and circularity. And so while optimizing healthcare utilization and delivery and implementing local sustainability solutions is critical, we just need to recognize that the majority of our emissions are associated with our supply chain. And so while we can reduce the amount of stuff that we're using in healthcare, we're never going to eliminate it completely. To achieve net zero emissions, we're really going to need to work with our suppliers, and we're going to depend on our suppliers to decarbonize their own operations, design for sustainability, and increase product circularity. And that's why systems like the NHS are using their leverage as purchasers to demand this of their vendors. So this is from a report from the NHS that basically states that before the end of the decade, the NHS will no longer purchase from suppliers that do not meet or exceed our commitment to net zero. And I think we may start to see a similar kind of approach in the US. I'm not sure it's going to be as much of a stick as this, but we're already seeing health systems starting to engage with their suppliers and share how important it is for them to be purchasing products that are associated with a smaller environmental impact. And I'm happy to talk about some of those initiatives later if people want to hear about that. Much of our environmental impact is related to the fact that we've largely become in healthcare a linear economy in which resources are extracted, manufactured, distributed, consumed, and then thrown away. And this take, make, and waste approach is really I would say the product of a historical disregard for the environmental impacts of clinical care, an aggressive pursuit of hospital infection prevention, and a regulatory environment that favors single-use products, as well as a desire to simplify complex operations and the perception of cost savings among hospitals. Not to mention, I think the manufacturers see financial benefits here too, because it's a way of selling us more product. And so I'm sure you can understand how it has a detrimental impact on the planet and human health. And so that's why I think increasing there's interest in, I think, the health sector, trying to understand how we can move to a circular economy, which minimizes waste and the loss of the finite materials and embedded energy through design of products that can be maintained, reused, refurbished, or remanufactured, or reprocessed and recycled. And an environment like healthcare, where infection prevention and reliable operation are critical, that approach to circularity has to be carefully considered. But the circular economy mindset assumes that these are requirements that can be met through careful design and without compromising the regenerative nature of this system. And so I'm hopeful that in the next decade or so, we're going to see a significant shift towards these types of manufacturing process, but it is complex. And then I think one other thing I just wanted to discuss was how we begin to kind of talk to patients about this in the clinic. And interestingly, there's some data that's come out in the past few years that show that physicians are really a trusted source of information on the health impacts of global warming. So this is a study that asked people to rate who they would trust most to receive information about the health impacts of global warming. And the most trusted source were primary care doctors. So I think there's some reluctance on our part to talk about climate change with our patients, but actually we should be embracing the fact that we're a trusted source of information and that patients are looking to us to provide information about how climate change is affecting their health. This is a study by the same authors that came out subsequently. And what's really fascinating is that many of us who are thinking about how we should be engaging on this topic with our patients feel like we should be trying to gauge our patients' kind of their own kind of feelings about climate change, which we know is a highly political topic, and are trying to be careful to tailor our comments appropriately. But what this study actually shows is that kind of conservative Republicans, who I would say are probably like in general more resistant to hearing about climate change or believing in the kind of that this is a man-made crisis, are actually the ones who are most likely to be interested in kind of hearing about climate change's health impacts from their primary care physicians. So I think it provides me with some grounding and helps me recognize that this is perhaps something that I should just be discussing with all of my patients in the right clinical context. The paper also kind of highlights a really powerful way of messaging this, and so we don't need to go through this in great detail, but I think this is the people who publish this work, they are communication experts, and so what they have found through their research is that there's a simple message that can be communicated that's really effective at helping people understand how climate change is affecting human health and why this is something that we should be taking seriously. And basically, they break it down into these 5 points. It's real, it's us, experts agree, it's bad, there's hope. And if we can all kind of use that same messaging, it can be a really powerful way of influencing people's feelings and receptivity to further information and learning about climate change and its effect on human health. And then lastly, I would say kind of our role, we have a role as advocates as well. We are a trusted source of information about climate change. And so we should be using that as health professionals to really try and shape policy around climate and begin to reframe climate change as a public health issue and less as an environmental one. And then I think the very last thing I wanted to emphasize is some of the work that's happening a little more locally here at Mass General Brigham. It turns out that Mass General Brigham has been a fairly progressive organization when it comes to healthcare sustainability for a long time now. So this work really started back in the 2000s, and I will credit a few people, including John Maservi, who is in real estate and facilities at MGB, for really being a leader in this area, not just at Mass General Brigham, but within the US health sector more broadly. And not surprisingly, a lot of this work began back in the 2000s when a main driver was a focus on reducing the cost of all the energy that we were purchasing. And so implemented an aggressive energy conservation initiative that was highly effective in reducing our overall emissions and energy consumption. That work led ultimately to kind of our first strategic energy master plan. And then around this time, there were other health systems that were similarly trying to begin to do more around sustainability. Again, it was largely focused around energy at the beginning. Increasingly, they became more focused on eliminating chemicals of concern from the healthcare setting. And I would say this work has really, the pace with which it's been accelerating has been really dramatic over the past 5 years or so, not just within Mass General Brigham, but I think more broadly within the US health sector. There's a real groundswell of activity here, which is very exciting. And there are a lot of new initiatives that are really, I think, driving this work forward right now. I'm not going to go through this in great detail, but I just wanted to point out a few kind of initiatives that are happening at MGB. One is our involvement in climate resources for health education. This is a program that was started to really provide medical schools and graduate medical education with freely available evidence-based resources and curricular tools that could be easily embedded into other curricula because there's been a real thirst amongst medical students and trainees for more information about climate change and its health impacts in their curriculum and healthcare sustainability, I should say, as well. A few other things. A few of the hospitals in the MGB system have joined the Cool Food Pledge. This is a really kind of interesting program led by the World Resources Institute that's trying to get large institutions and organizations to dramatically reduce emissions associated with their food services. And so as part of that, there's been a significant shift towards pushing plant-forward menus at some of our local hospitals. The U.S. Health Sector Climate Pledge, so we at MGB have committed to reducing our emissions by a certain amount over the next 10 years, but also kind of ultimately achieving net zero by 2050. So this is this is the U.S. Health Sector Climate Pledge that was put out by HHS now a few years ago. And then we have started, or actually we just completed our very first MGB-wide greenhouse gas inventory that we're going to be using to really try to guide some of the work that we're going to be doing moving forward to reduce our emissions in order to achieve the goals that have been set forth as part of the U.S. Health Sector Climate Pledge. In parallel with that, we've also started on our MGB Decarbonization Master Plan, which is very focused on just reducing or eliminating Scope 1 and 2 emissions for all of our facilities. And that project is just the master plan itself, the technical document is just wrapping up as well. So we're going to be moving into a phase of implementation soon. And then so I just wanted to share what we learned from our greenhouse gas assessment. Consistent with other health systems, Scope 1 accounts for about 9% of our emissions and Scope 2 for about 7%. But the vast majority, 84%, is due to Scope 3. Our largest contributors are purchased goods and services, with the carbon that's associated with the manufacture and transport of all the supplies we use to deliver care and conduct research. Capital goods, so that includes construction and renovation of buildings, but also expenditures on durable equipment like MRI machines. And then some other notable categories include upstream fuel and energy. Those are emissions that are associated with the extraction, production, and distribution of the energy we consume. So if we reduce how much energy we're consuming, our upstream fuel and energy emissions go down in parallel. Employee commuting and patient travel also make up significant contributors to our overall footprint. And if we look a little more closely at purchased goods and services, we can see that pharmaceuticals represent about 10% of our footprint, but importantly, this doesn't include emissions from pharmaceuticals that are sent to retail pharmacies in the outpatient setting. In that study of the NHS, emissions that were associated with prescriptions from primary care were greater than those from medications that were administered in the hospital. So presumably, we have a carbon footprint that's at least this big, if not larger, associated with our with pharmaceuticals that are being sent to outpatient pharmacies. Much of the remainder of this category is made up of all the consumable products that we use. And so lastly, I'll just point out that this doesn't include investment holdings, which are also likely a substantial contributor. And so, as I mentioned, now that we have the results of the study back, we're working on beginning to identify where can we strategically identify opportunities to really begin driving down our emissions. Obviously, a lot of our work needs to focus on scope 3, but that's challenging because so much of it is out of our direct control. But we, like many other health systems that are interested in doing this work, are starting to engage and collaborate with our suppliers in a way that we haven't in the past, with the goal of collaboratively finding ways to reduce emissions from our supply chain. So lastly, I just want to say, I want to point out kind of, well, what is it that individuals can do? So in your clinical practice, I would just emphasize prioritizing prevention. I think we talked about why that's so critical, minimizing low value care and cascades, avoiding resource-intensive care settings, choosing reusables instead of disposables where possible, reducing and properly segregating our waste. Think carefully about transportation to and from work, as well as professional travel. I think that we have a responsibility to incorporate this into our teaching for both our undergraduate and graduate medical trainees. And then advocacy is an area in which I think we have such potential and opportunity. Like I said, the voices of health professionals are highly influential and I think are really critical to reframing climate as a health issue as opposed to an environmental one in a way that has significant potential to drive change. And then lastly, I just encourage you to stay informed and engaged. There's a lot happening in this space right now, which is both exciting, but it's also hard to keep up with. But I'd encourage people who are really interested in these issues to begin learning more about what's happening both here in the United States, but also across the world. So with that, I'm going to end. I'm happy to take questions. And I just encourage people to also feel free to reach out to me if they have other questions. I'm always happy to talk about this. So thank you.
Thank you very much, Dr. Furie. This has been wonderful. Thank you for the overview and the very rich content that you've given us. We do have some questions for you. First of all, I'd just like to respond to the very last slide that you had where you mentioned advocacy and encouraging people to remain informed and get engaged. And as you said, there is a lot of information out there and a lot of places to go. So are there any like first port of call that you would suggest people should go to start getting informed or increase their knowledge base?
One resource that I think is great is the Medical Society Consortium for Climate and Health. And they both, I think they have useful resources for implementing in your own practice, but also they do a lot of advocacy work. And so I think it can be a great place to go and learn about how you can get more involved in advocacy at largely at the federal level, but within your own medical society as well.
Yeah, we have a few minutes left for questions that I'm going to just field from our audience. This one might be a big one. How do you get buy-in for coverage from insurance on things like Tai Chi versus low value care, like medication or surgery that is covered?
Yeah, I think it's a big challenge, and it's probably one of the reasons we don't use those approaches more frequently. But I think that's why I was making the point that we need to begin kind of recognizing that not that our interests are the financial and the environmental interests are aligned, and using the kind of environmental argument as a way to further justify coverage for these services. But I agree, it's a major frustration. We know there are services that are out there and available that are effective, more effective than many of the ones that are being offered to our patients, yet they're not available because there's an insurance cover. So I think, again, this is kind of an area for advocacy. It requires us kind of pointing out that that there's not a lot of the current structuring of the system is not rational, and it's not benefiting patients, our finances, or the climate.
Thank you for that. Another question from, I think her name is Kitsa Catherine. Are there any buyback programs for medical devices which can be subsequently used for those or other products?
So there are, and so that's what I was referring to in terms of the single-use device reprocessing. So many hospitals use these programs because they're cost saving. And common places for reprocessed devices are in the OR, electrophysiology catheters can be reprocessed, and some of the things that we use just on a medical floor, like the pneumatic boots to prevent DVTs, for example, those can be collected and reprocessed. So there are many ways in which to kind of to do this and to take advantage of these opportunities. It can be a little complicated. The contracting can be a little complex, but I think many health systems have decided to invest in kind of figuring that out because there's so much opportunity from a cost saving perspective. And I'll just add that again, in order to collect these devices, send them back to, it's actually a third party who reprocesses them and buy them back. That process has to be FDA approved. And so there's certainly like guarantee in the safety and the reliability of the products that you are purchasing back in a reprocessed form. They work as well, if not better, than the original devices.
Okay, and just a couple of short questions here.
Yeah.
Do you know of any resources or cookbooks for the planetary health diet?
I don't actually. I think actually if you go to the planetary, I would go to that. It's the website is eatforum.org, and there are a lot of resources there. So I wouldn't be surprised if they have some recipes there, but I don't know of a specific book for the planetary health diet. But if anyone knows of one, I'd be interested in getting it myself. So.
Okay, so we'll look into that. And last question is in relationship to MGB's efforts. You kind of detailed that, very rich trajectory from the 2000s, and that it's increasing in terms of the activity now. So one is how can people get involved with MGB's efforts? And people just want to know, is the analysis that you refer to, is that an ongoing cycle? Or is that just a one-off, or what's the next steps?
Yeah, great question. So in terms of getting involved, I think this is one thing that we have struggled with a little bit because we're still working to define the specific initiatives that we're going to be focusing on. So I think there's more to come in terms of how you can be involved in kind of that broader work. I think each of us has a role in beginning to identify what are the areas of waste within our own kind of sphere in which we work. Both to begin modifying our own behaviors, but also because I think it's like those of us who are doing this and talking about it at the system level don't always have insight into what's happening kind of on the ground in every clinical area in which people are working. And so there's some element of kind of crowdsourcing where there are significant opportunities to begin reducing our environmental impact. And I think what we often find is like once you start looking for this, you can't not see it anymore. You will kind of see these areas of waste everywhere throughout our system and throughout kind of like our process of delivering clinical care. And it's really helpful to begin kind of making a list of all those opportunities. So that's one way. I do think there'll be more to come over the next kind of few months or so. In terms of whether this is going to be ongoing, our goal is, yes, to continue doing this both as a way of monitoring our progress over time, but also because I think our goal is to be more transparent about what our environmental impact is. We think this is a critical way of driving change within the health sector, and I think we're hopeful that there will be increasingly be platforms for health systems to be essentially publishing their data, and that health systems may be held accountable for their environmental performance. So in the same way we kind of measure and report on quality, we should be doing the same thing in terms of our environmental impact.
I see we have a couple more minutes. So there is one related question to what you just said. So in terms of these changes that are happening at MGB, do you feel it's starting to change the culture of employees at all? How do you see that surfacing?
I think what we see when we go out and talk to people is that people have like a thirst for this work and information. I can't, it's so rare that if ever, that we go out and talk to people about this and they aren't enthusiastic about doing more to reduce the environmental impact of healthcare. Yes, there are things that can be, I think there are areas, there's a lot of kind of low-hanging fruit that would have little impact on the way in which we deliver care. Then I think there are more kind of challenging issues. This kind of idea of balancing minimizing our environmental harm while simultaneously ensuring infection prevention is a great example, right? So how do we begin to implement processes where we're using kind of more reusable goods as opposed to single use, while also ensuring that we're delivering care safely? And then I think those are the kind of conversations that are more complicated, but in general, I would say there's a lot of enthusiasm for this work. I think the challenge has been in how do we begin to kind of prioritize our initiatives and then really go about implementing it. But again, much of this work that's been done to date has been focused on kind of energy procurement, energy conservation, and that happens kind of like behind the scenes largely, and it's not always something that's directly under the control of like clinicians and our staff. But now I think with this kind of real groundswell of interest in this area, we're beginning to see it entering the kind of like collective consciousness of people who are just directly involved in patient care. And so yes, I think there's more awareness of it. I wouldn't say we've gotten to the point where there's dramatic change in culture yet, but that's our goal. Like, I think none of this will be successful unless we can get everybody to believe that environmental sustainability and stewardship is a fundamental part of their daily work.
Wonderful. Thank you. That's an excellent way to close today's grand round. So thank you very much, Dr. Furie, for your presentation, sharing your time with us.
Yeah, my pleasure. Thank you all so much for having me.
Thank you. So I just have a few announcements to make. Next month's grand rounds will be on the topic of individualized biopsychosocial assessment and treatment of back pain, and that will be presented by Dr. Gert Bromford. He's a doctor of chiropractic and professor at the Integrative Health and Wellbeing Research Program at the University of Minnesota. So that will be on Tuesday, May 7th. So please do join us for that. And a couple of other things which we may have already mentioned previously, but we are very excited about our network forum that is coming up. And that's going to be in December. So December 9th and 10th. Please do save the date for that. It's going to be a 2-day conference, and we're returning in person to the Harvard Medical School's Joseph B. Martin Conference Center. So look forward to seeing you there. And lastly, just following on from today's wonderful presentation and in the theme of Earth Day, we're planning on holding a 1-day virtual symposium on planetary health as part of the OSHA Collaborative for Integrative Health Initiatives. So that's about 11 different OSHA centers from across the US and Sweden that actually take part in this. And we would love to invite you to be part of this event in the fall of 2024. So stay tuned for that. And lastly, this programming in regard to planetary health and how our healthcare system affects both individual health and the planet is new at the OSHA Center, relatively new. And if you have enjoyed and appreciated what you've heard today and would like to see more programming in this area, please do support us at theoshacenter.org with a donation. So learn more about us at oshacenter.org, and hopefully see you next month at our next grand round. So thank you very much all.